Good morning or good afternoon for you guys. We will start at quarter after the hour, so don't go away. We're just waiting for other folks to join. Can you hear me?
Hello, yes.
Oh, okay, good. Just wanted to check. We'll wait till 15 minutes after the hour and then we'll begin just to give people time to join.
Okay. Okay. Yes. Yes, I'm ready, doctor.
You want me to go ahead and get started?
So welcome.
Good morning or good afternoon where you are.
Welcome, Dr. Bhatt.
I was going to wait till 10 minutes after, then we'll get started. Is that okay? Oh, it is 10 minutes after.
Am I heard?
What's that?
Am I audible?
I can hear you.
Shall we start?
Yes. Okay, good. Sounds great. All right. Well, welcome everybody. I'm Brad Winters. I'm the Division Director for Critical
Welcome,
Care.
everybody. Welcome to the Global Critical Care Fellowship Seminar. Today we'll have seminar on resuscitation and management of burn patient in the ICU by our guest, Dr. Brad Winter. He's a professor of critical care, medicine, anesthesiology, and surgery division, and he's a division director as well as adult critical care medicine from Johns Hopkins University. So Dr. Brad and I will be the taking the questions at the end of the sections. So I welcome everybody to have good seminar sessions. So I think Dr. Brad can continue.
Okay, great. Well, welcome everybody. Thank you for joining today. As you heard, we're going to be talking about burn resuscitation. Burn patients, whether you work in a specialized burn ICU like I do, or whether you work in a general ICU, you're very likely to see burn patients at some point during your training and your career. And I will start off. I have a couple of disclosures I need to make. I receive compensation from the Philips Corporation, excuse me, for consulting on patient monitoring. And I have an equity interest in a software company called Intellex Incorporated. But neither of these are relevant to today's conversations, and I will not be discussing any off-label use of any pharmaceutical agents or other technologies. So burn is a very unique kind of injury compared to trauma and surgical trauma and sepsis, and the management of burn differs rather dramatically. And I think, as everybody's probably generally familiar, there are three major types of burns. There's what's referred to as a first-degree burn, which is superficial. It's very painful. It leads to red skin, blistering, and swelling, but it rarely leads to the need for ICU care. Second degree burns can be broken down into both what are called deep and partial. The epidermis and the dermis are damaged, and the burnt area is usually mottled and red mixed with blanched areas and dark red and pale areas. It is also painful, and it also blisters a lot like first degree burns do. Patients who land in the ICU with burns often have a large component of their burn involving second degrees. They also may have some small areas of first degree, but second degree burns are frequently a major presentation piece. And of course, the third degree burn is the full thickness burn. This is all the way down to the hypodermis. And what's interesting about this, and it's not surprising, is it's not as painful a burn as second or first degree burns because, in fact, the burn is so deep that it destroys the nerves. So the patient actually does not have a sensation of the burn. The burned area is usually very charred. It's completely blanched. It can feel dry and leathery. And this kind of burn is the most serious kind of burn. Most patients who come in have a mixture of these. Usually second and third degree burns, again, as I said, form a huge component of large burn areas. Now, burn care has to be broken down into a series of phases. And the first phase involves the initial assessment of the patient, figuring out how much of the body is burned in terms of total body surface area, How much of it is second degree and third degree? We don't worry as much about the first degree component, as well as any other associated injuries. So people who are in a house fire, may have primarily burns, but people who are in motor vehicle accidents who also get burned or are involved in explosions, like propane tanks, etc., not only will have burns, but they could have other injuries such as abdominal injuries, thoracic injuries, orthopedic injuries. And it is not uncommon for us to also see traumatic brain injuries mixed with a burn injury. And this can make the patients extremely challenging because you're trying to manage these other traumatic injuries along with the burn injury. But specifically, driving at burn injuries, after you do the initial assessment, understand what has injured the patient and the degree of the injuries, we then have to move into the acute burn resuscitation. And that's actually what we're going to focus on mostly today. And so I'm not going to go into too much detail about that right now because we're going to spend a lot more time on that for the rest of the discussion. Once the acute burn resuscitation is winding down, I wouldn't say it is ever completed, but it does tend to wind down a lot. We have to work on wound closure, and wound closure can involve a lot of excision of burned and devitalized tissue, and then covering the tissue either with artificial materials or ultimately with the patient's skin. This can become a very challenging process when we have very extensive burns. So people have burns over 75% of their body often do not have a lot of skin to work with for wound closure. And that's when we turn to a lot of artificial materials. And in the United States now, we actually are using cultured cells from the patient. So during part of the wound closure process early on, we will actually take samples of cells from the patient's normal skin. We send it to a company. It's incredibly expensive. And they actually culture the patient's cells in cell culture and send it back to us for application to help cover the patient's skin. It is an incredibly expensive, resource-intensive process. Um, many countries around the world just don't have this resource. Even inside a country like the United States, it's incredibly expensive. And then finally, once the wounds are covered and healing, we move into rehabilitation and then reintegration back into normal life. This can take months and it can be very, very difficult. Depending on the kinds of burns, people may have to reevaluate a lot of what they do, both in terms of their employment as well as things they do for fun. I can think of several people I know that we've had as burn patients who were musicians, and their burns affected their hands and their ability to continue in their career as somebody who plays a musical instrument. So it can be very life-changing for patients. And the other problem with it is the rehabilitation pretty much is for the rest of your life. People who have extensive burns often have to come back for multiple surgeries over multiple years. Because what tends to happen is over the long term, the scarring process associated with extensive burns tends to be progressive. It doesn't stop at a certain point. You tend to continue to develop scar throughout your life in the areas of the burns, and patients often have to come back to have these scars operated on and released either through surgical excision. In many countries, they now use laser systems to release the burns because it does less damage and leads to less rescarring. So rehabilitation and reintegration becomes basically a lifelong activity. Wrong direction. Okay. So phases of burn care. Again, we said burn needs to be viewed as a series of phases. Again, we talked about this, and we are going to focus today on acute burn shock resuscitation because this is probably the most challenging component of the ICU care of a patient with a burn. Burn patients experience many, many other risks aside from the burn, and we have to keep these in mind as we're managing the patient in the ICU. Obviously, they are extremely prone to hypovolemic shock, and that's what the early resuscitation is really focused on. But these patients also may develop hemorrhagic shock. Now, they may have a hemorrhage associated with their initial injury, because as I said, a lot of times patients come in not only with a burn, but they come in also with other traumatic injuries. But they are also at constant threat of infection. And this can set in very early in their course, and throughout their entire course in the ICU, infection is probably one of the biggest threats to their lives after the initial burn management. Patients are also incredibly prone to developing acute respiratory failure and acute respiratory distress syndrome. A lot of this can be secondary to chemical and thermal pulmonary injury, so-called inhalational injury. And we'll talk a little bit more about that in a few minutes. But also the burn and subsequent infections can lead to severe secondary inflammatory responses, septic shock. These patients often need many transfusions, particularly if they have hemorrhagic shock. And these can all trigger things like respiratory failure and acute respiratory distress syndrome. The other thing that tends to drive hemorrhagic shock, even if the patient doesn't have an initial injury that leads to hemorrhage, is the surgical wound management. So when the patients go to the OR to get the dead tissue removed in preparation for wound closure, even though a lot of the tissue is dead, you have to resect it down to live tissue, and that tends to lead to a lot of bleeding. Particularly since many of these operations for extensive burns have to occur over a period of 1 to 2 or sometimes even into 3 weeks, depending on how badly the tissue is burned. And one of the things that happens with burns is as the tissue tries to heal, there's a lot of what's called neovascularization. A lot of very small blood vessels develop fairly quickly. Now, these are important for the wound healing process, but as you can imagine, for a surgeon trying to debride and remove the tissue, getting into a lot of these small blood vessels can lead to huge blood losses. So if you're an anesthesiologist or anesthetist who's taking care of these patients in the OR, they bleed a lot. And they often come back out into the ICU still hemorrhaging. And they could develop coagulopathies and disseminated intravascular coagulation, leading to massive hemorrhage. So it is quite a challenge to manage these patients. The on average ICU care will generally, based on data in the literature, last anywhere between 1/2 to 1 day per percent of total body surface area. So, for example, if you have a 50% total body surface area burn, the average time you will spend in the ICU is about 50 days. So it is a very, very prolonged course. And as you can imagine, it turns into an incredibly expensive and resource intensive care process. When you think of a lot of our other people who are in motor vehicle accidents, people who come in, with sepsis from pneumonia and other infections, we usually get people, better and out of the ICU with those diseases much more quickly. Burn patients are going to be in your ICU for weeks, sometimes months. We've had patients in our ICU as long as 10 and 12 months before they were well enough that they could actually leave. Other risks that they experience, of course, mortality. The mortality tends to have what's known as a bimodal distribution. Usually the mortality can be very high up front, usually due to the shock and other injuries that they may have. But then later on in the course, as you can imagine, when infection starts rising as a major threat to the patient, we tend to have another spike in mortality. So people, burn patients, even if they get through that first few days of the burn and the burn resuscitation, they have a high risk of mortality later on. Infection and multi-system organ failure actually probably kill more patients than the actual initial burn. The other thing to consider is 1/3 of burn patients also experience inhalational injury. This is usually associated with a burn occurring in an enclosed space, such as a house or an automobile. Although, again, a large number of burn patients may develop ARDS, acute respiratory distress syndrome, with or without an inhalational injury. And inhalational injury can, again, contribute substantially to the mortality. So let's move into the actual resuscitation. So you've got our background. We realize what we're getting into with a burn patient. We know it's going to be a very long process, even at the ICU level of care. And then, of course, once they get out of the ICU, if they get out of the ICU, initial triage, and rapid management of these patients is really, really important. Of course, the ABCs apply as they do in any trauma patient. One in particular thing that we have to consider, and this is usually done in the field before the patient even gets to the hospital, but certainly needs to be assessed in the ED, emergency department, if it isn't managed outside the hospital, is signs of inhalational injury. If the patient has signs of inhalational injury, they need to be intubated immediately. Again, as I mentioned before, inhalational injury tends to occur when the burn exposure is in a closed space, such as a house or automobile. But if you see soot in the airway, in the nares, in the mouth, or especially if the patient has a change in their voice and it's stridorous, squeaky, or gravelly, you have to assume that they have inhalational injury and they should be intubated. The reason why you need to intubate these patients early is if inhalational injury has occurred, two major pathophysiological things happen. We'll talk about it in a little more detail in a few minutes, but I'll just tell you what they are now. Thermal injury from the hot smoke that they're breathing, then also the chemical reaction to what's in the smoke. Smoke, even if it's just from wood, contains a lot of very nasty, irritating chemicals. And if somebody happens to be in a building or in an automobile, think about all the stuff inside of those areas. Furniture, plastic, furniture has plastic in it, car parts have plastic in them, paint, other things break down into really toxic chemicals. These can lead to very, very rapid edema. And of course, the vocal cords can swell shut very, very rapidly. So if there's any sign of inhalational injury based on these factors, you really need to intubate the patient quickly, because even if you wait 10 minutes, a half an hour, you may have trouble intubating them because their airway will swell shut and they'll wind up with an emergency tracheostomy. And that can be very challenging to do if their neck is also burned, because trying to do a tracheostomy emergently through burned tissue is not good. Once you've gotten through the ABCs, airway, breathing, and circulation, and here particularly airway, we very rapidly move on to the total body surface area calculation. And the reason why this is important is this is going to define the next 24 hours of care in your ICU. And there are two major ways to calculate it. There's something called the rule of nines, and then there's something called the Lund and Browder calculation. Once you do, and we'll talk about this in more detail in a few moments, after you've done your total body surface area calculation, which is going to drive a lot of your process over the next 24 hours, you also move on to your secondary survey for other life-threatening injuries, as you would for any trauma patient, particularly if the burn was associated with some other sort of trauma, such as a motor vehicle accident. And while you are doing this resuscitation after the initial triage, you have to be attentive to performing escharotomies. Burn patients, because of the swelling that occurs, and as we move into the actual shock resuscitation, the fluid that we give to the patient tends to lead to a lot of swelling and tissue edema. And since it is burned tissue and not normal, unfortunately, it tends to absorb a lot of the fluid that we are going to give the patient, but the fluid doesn't come back out. And so what happens is swelling occurs very, very rapidly. Literally between the time the patient gets burned and by the time they arrive in your ICU, they can have massive swelling, especially if they have been getting resuscitation between the site of where the burn occurred and your facility. And escharotomies are often necessary to release the tissue to prevent compartment syndrome and loss of limbs, as well as other complications, which we'll talk about in a few more minutes. Does anybody have any questions so far? Let me ask a quick question right up front. How many folks have already taken care of burn patients in your ICU? You can just put your hand up on the screen if you want to, or you can open your mic. Nope. So far, no one's volunteering. So um, you will eventually wind up having to take care of one of these patients. So it's good to understand the management. All right. So rule of nines. This is probably the most common way we calculate total body surface area of burn. And it's called the rule of nines because basically we break up the body into areas of 9%. So we've got the chest, the abdomen, each arm, the head, the front of the legs, the back of the legs, the lower back, and the upper back, and the general area is 1%. So you've got 11 areas times 9% each is 99, plus the generals would get you to 100%. So this is probably the most common way we do this. And, if only half the chest is burned, you cut this in half. So, if you have a burn on the chest, you don't necessarily add up the full 9%. But if this whole area here is burned, you would call it 9%. But if it's only burned on the left side or the right side, you would call it 4.5%. And there is some, wiggle room in these calculations. If you ask 10 different burn surgeons and burn intensivists to calculate up a total body surface area, they're probably going to be within 5% of each other, but they're not necessarily going to land on the exact same number. But if you're within 5% of each other, that's a fairly reasonable range. And this applies to adults over 14 years old. Obviously, most places people aren't considered an adult till they're 17 or 18 or sometimes even older. But because 14-year-olds generally are of adult size, if the patient is over 14 years old, we usually apply this rule of nines. In children, though, we modify the rule of nines. Now, they call it the rule of nines, but it doesn't really follow the nines. It sort of follows the nines for the legs and the arms, but because of the relative size of the head compared to the rest of the body in children, the head gets a proportionally larger a component than it does in adults. And likewise, the thorax also gets a higher level of assignment. And you can refer to these as nomograms. You could have these on cards. These are pretty easy to find, so you could do the calculation. If you take care of children frequently, you'll probably have these committed to memory. And of course, in infants, it's completely different. The rule of nines, if you want to talk about actual numbers of nine, they kind of go out the window. Children, because they have a very much larger proportion of their head size to the rest of their body, their head accounts for roughly 1/5 of the burn of body surface area, and the other areas are much less. The London Browder calculation actually divides the body up even more, which is why it is probably a little harder to use and not as popular. At our burn center, we generally go by the rule of nines, um, just because it's really hard to remember all these individual percentages. But if you have the graph and you have the chart and you want to use the London Browder, you can get a little more refinement in your total body surface area. But again, the rule of nines is actually much easier to remember, and so not as many people like to use this one, but it is useful. So who actually needs an aggressive resuscitation? Who needs to be in the ICU? Generally speaking, a total body surface area burn less than 15 to 20% does not require a burn resuscitation beyond normal fluid management. Okay. So in our ICU, when we calculate the burn total body surface area of less than 20%, we actually do not admit that patient to our ICU. Okay. And we do not move to one of the formulas that we're going to talk about in a few minutes. So um, we just resuscitate those people through the normal process of normal resuscitation based on what we calculate their regular maintenance fluid needs are, and we kind of just follow their urine output, their blood pressure, their general perfusion. There's no specific formula that is used for less than 20% total body surface area. Some institutions put that cutoff at 15. At our institution, we use 20. However, if you are caring for patient with children rather, greater than 10% requires of the burn resuscitation, where you calculate that total body surface area and you apply one of the formulas that you'll see in a few minutes. Okay. There is a caveat though. People who have less than 20% may need additional resuscitation depending on other factors. So extremes of age, as we already said, children, we use 10% as a cutoff, but extremely elderly people may need a more larger resuscitation because they can't handle the injury as well as a younger person would, even if it's less than 20%. And in particular, as I mentioned before, inhalational injury. As you'll see as we talk about things, inhalational injury can be a huge caveat and have a huge impact on our management. Yet, as you'll see in a few minutes when we talk about the burn resuscitation formulas, inhalational injury doesn't get put into the formula. And so it comes to you as the intensivist to kind of guesstimate, to make a guess about how much the inhalational injury is contributing to the patient's fluid needs and adjust them accordingly, which is unfortunate because it creates a huge amount of variability. The problem is we just don't know how to put a number on the inhalational injury and adjust the formulas. So it really comes down to your skill and your expertise and observation, which is where medicine is a bit of an art. It's science, but there's also an art to it. And a lot of it comes from your experience and your knowledge. The other thing that you also have to keep in mind about the caveat is even if you're just below 20%, like let's say you calculated at 18%, but it is full thickness all the way down to the bone, you may choose to move that patient into the ICU resuscitation group. So again, it's not a hard and fast rule. It partly depends on how bad the burn is. Now, burns that are less than 20%, usually in my experience, are not a huge component of very deep. They might have a small area. But you do want to keep an eye on these patients, but you don't necessarily have to move them into the ICU level of management and attack them with a large resuscitation. And when we talk about the formulas, you'll see why I use the word attack. It is an aggressive treatment. So let's talk about a little physiology before we move into the formulas. You guys probably already know a lot of this, but we'll go through it. The pathophysiology is that burns lead to a dramatic increase in the permeability of all the blood vessels down at the small arterial and capillary level. This leads to profound fluid loss, much worse than septic shock ever does. Okay, there's huge release of histamine, bradykinins, nitric oxide, a whole bunch of oxygen radicals, tumor necrosis factor, interleukins, prostaglandins, and thromboxane. Basically, your entire inflammatory cascade is activated. And basically, large endothelial gaps occur. The endothelial cells contract, as you can see in this picture, creating huge spaces. White blood cells, etc., move through those spaces, but fluid pours through those spaces into the interstitial tissue. The oxygen radicals and xanthine oxidase there take all that oxygen and generate significant edema. Th2 cells upregulate. This creates a suppression of your immune system. So all these macrophages, these monocytes that are moving through here, become inactive or less active. Cytotoxic T cells and T cell proliferation all occur, and this further suppresses the immune system. So you're developing a huge amount of edema. You've got tissue that doesn't have good blood flow because it's been infarcted, and now you're suppressing the immune system with this overwhelming inflammatory response. So as you can imagine, these patients become wide open risk for subsequent infections. And these, again, infections, as I mentioned earlier, can set in really, really quickly. The environmental loss of fluid is massive, absolutely massive, into the bed sheets, into the gauze that gets wrapped around the patient's wounds and into the air. One of the most important things with burn patients is you got to keep them warm. You absolutely have to keep them warm. They will get so cold so quickly through evaporative heat loss that their body temperatures can plummet. And that can lead to all the problems that we know are associated with hypothermia, such as coagulopathy, which will make the burns bleed more, and cardiac arrhythmias. You absolutely have to keep these patients as warm as you possibly can. And I can tell you, this is a major struggle, but you need to be really attentive to it. As I said, all this dead tissue can very rapidly become infected with bacteria and or fungus. In fact, we not infrequently see when patients get to the OR after that initial resuscitation to get their first surgeries to remove the dead tissue, we often find it's already got bacteria in it. And it's the bacteria that were probably already on their skin to begin with, but now that it's burned, the bacteria manage to survive the burn and set in. But also environmental bacteria also that are just in the air when the patient's being transported and in the environment that you move the patient into also can contribute to it. And infection, as I said before, often becomes the source of delayed death in extensive burns. A little bit more about pathophysiology. As I said, cell-to-cell adhesion breaks down, get huge gaps. The other thing that tends to occur is because of the actual thermal injury, blood vessels thrombose, as you can see in this picture. They basically just clot off, which devitalizes the tissue even more. The endothelial cells lose their glycocalyx, which is the outer carbohydrate protein moieties that the cells communicate through to components in the bloodstream, and this can lead to cellular dysfunction and cellular loss. This can also trigger disseminated intravascular coagulation, as I said. And once you get into disseminated intravascular coagulation with an extensive burn, your patient's mortality skyrockets. And these responses are generally in proportion to the size of the burn injury in the site. The small burns may only exhibit local changes and not become systemic, but large burns, again, over 20%, usually lead to severe systemic effects at a distance from the burn. And of course, as you can imagine, all of this leads to cardiac output dropping and shock ensuing, and stress cardiomyopathy can occur secondary to all those inflammatory mediators, leading to a layer of cardiogenic shock on top of hypovolemic and hemorrhagic shock. So these patients can have multiple shocks all at the same time, which of course increases the risk of mortality. In fact, the risk of mortality is age related. People who are under the age of 50 can generally survive burns that are up to 75%. People over the age of 50, when you have a burn that involves more than 75% of your total body surface area, regardless of thickness, mortality skyrockets to be in excess of 80 to 90%. And if you're 80 years old and above, and you have more than 75% burn, your predicted mortality is essentially 100%, despite good therapy. So these injuries are devastating. So let's come to the resuscitation formulas. So this is, this is the meat. So after we've done our initial assessment, we've controlled the airway if we've got inhalational injury, and we calculate our total body surface area, and we account for other life-threatening injuries such as hemorrhage or severe traumatic brain injury. We have to immediately start resuscitating this patient. In fact, in the field, when the patient's being transported in by ambulance, the ambulance needs to hang 1 or 2 liters right up front. Ideally, by time a patient gets from the burn site where they got injured to the ED, hopefully they've already received at least 1 to 2 liters to start warding off that shock. When patients arrive in the ED with no fluid, they are already in deep trouble and you're already way behind. So we immediately jump to getting the total body surface area calculation, even if it's a little off, because we've got to start getting the fluid in. And as you can see, there's a lot of different formulas. There's the Brook, there's the Burn Budget formula, the Demling, Evans, Haifa, Harkins, the modified Brook, the Parkland formula. The Parkland formula comes out of Parkland Hospital in Houston, Texas, in the United States. It's a very famous trauma center, and they developed this one. The Brook one comes out of the Brook Army Medical Center in San Antonio, Texas, in the United States, which is a military hospital. They all, as you can see, are very focused on crystalloids, but they also add a lot of colloids. Some don't, some do. Probably the most popular ones that are used, at least in the United States now, are the modified Brook and the Parkland formula. As you can see, most of the formulas are based on an 8-hour time point, and then you reassess, and then the rest of the fluid is given over the next 16 hours for a 24-hour process. Virtually all of these formulas that are commonly used nowadays, some of these are much older, and are not used very much anymore, are focused on that first 24 hours of resuscitation. Some of them use materials that aren't really available anymore, like dextran is not commonly used, at least in the United States anymore. We'll talk about fresh frozen plasma a little more detail later. It is not currently part of most burn resuscitation formulas, but there is some evidence in the literature that may change that over the next few years. But as you can see, most of them are based on lactated ringers or normal saline or a mixture of lactated ringers or normal saline, and then some, again, add colloid. Modified Brooks is probably one of the most common ones. And again, Parkland. This is what we use at our hospital, but I will tell you we modify it. As you can see, the modified Brook and the Parkland formula, which are all based on total body surface areas, you can see there's quite a big difference between the two. The Parkland formula uses 4 milliliters per kilogram per percent of total body surface area, whereas the modified Brook uses almost half of that. We tend to use the we tend to target in between these at 3 mLs per kilogram per percent in our ICU, and at the 6-hour mark, not the 8-hour mark, if we are not achieving our goals, and we'll talk about what those goals are going to be in a few moments, we add in albumin. So that would be a colloid. So we will add in something from the original Brook. We'll add albumin at 0.5 milliliters per kilogram per percent body surface area once every couple of hours as an adjunct on top of the crystalloid. So I can tell you at my institution, again, we mix these two together, the modified Brook and the Parkland, and then we go back to the original Brook formula and we throw in colloid at the 6-hour mark if it looks like we are not achieving our goals. I would tell you that probably a lot of centers don't necessarily follow one formula exactly. They kind of mix them a little bit the way we do, and they kind of develop their own approach using these as guidance, but not as absolutes. And so, if you have a burn patient and you're doing this resuscitation, don't my advice is don't feel like you have to use this one or this one or this one. You can use elements from each one. Now, the American Burn Association, burn life support class that we all take in the United States for certification, just like advanced cardiac life support, does tend to focus on the modified Brook as what they teach. But that doesn't mean it's the only one that you can use. But that's the one you learn in the course. But again, we use in our ICU a modification that's between these two and throws in colloid if we think it's needed. The other thing you need to account for that I mentioned before is inhalational injury. And I apologize that this picture is a little blurry. It looked a lot better when it was smaller, but when I blew it up for the presentation, it got a little blurry. So this is inside someone's lungs with a bronchoscope. And as you can see, their lungs are full of soot, which is stuck on the wall. This soot is full of nasty, nasty chemicals, horribly nasty chemicals. And they are sitting there and they are creating a chemical burn inside the lung. Plus, when the patient inhales the hot gases, they have a thermal burn. And you can already see a lot of erythema, redness, and even some small areas that are starting to bleed a little bit. This does a lot of damage. And one problem that you'll notice, we'll go back to the formulas, they're all based on total body surface area. None of these formulas account for inhalational injury. There's no modifier in these formulas for inhalational injury, which is why I said earlier, it comes back to your clinical acumen, your assessment. How much is this injury that you're seeing on these bronchoscopic pictures contributing to your patient's inflammatory response? I think, as we all know, the lungs can be a huge inflammatory engine. Obviously, with ARDS, they become the primary inflammatory engine, but they can drive a much higher fluid need than you would normally calculate for total body surface area, regardless of which formula or mixture of formulas you choose. And so when we do the bronchoscopy on a patient, we look at this and this kind of creates in our mind, all right, we've got a bad inhalational injury. So we're probably going to have to give a little more fluid than the formula calls for. Maybe we'll air closer to the Parkland side of 4 mils as opposed to the modified Brook, which is only 2 mils. So we'll land a little closer to that higher amount. And we also know that our risk of developing acute respiratory distress syndrome is much, much higher here. There is a grading system for this, for how bad the inhalational injury is. But again, unfortunately, nobody has developed a good way to apply that grading system to the formulas for fluid resuscitation. So we don't know that if the grade is grade 1, that we increase it by 10%. If it's grade 2, we increase it by 20%. If it's grade 3, you increase it by 50%. We don't have a good way of doing that, and it winds up coming down to your clinical acumen. One other thing, that when we do a bronchoscopy, when we see inhalational injury like this through the endotracheal tube, we do try to wash a lot of this out to get those nasty chemicals out as much as we can. But I will tell you that frequently this material, this soot, is stuck on the wall and it can be very difficult to remove it. And then we come down to, all right, do we try to pull it off by sucking it off or using forceps through a bronchoscope to try to remove the chemical, or which can lead to a lot of bleeding? Or do we just leave it and just do a lot of good pulmonary toilet and try to wash it out as best we can? Generally speaking, we lavage with a lot of saline, try to get off what we can, and then we come back and we may bronch again in a few hours or the next day. My experience has been trying to pull this stuff off too aggressively can lead to a lot of bleeding, and that can lead to problems with oxygenation and all kinds of issues. So we just try to lavage as much as we can, as gently as we can, get as much of it out as we can, and we will often do repeat bronchoscopies depending on how clean it looks. All right. The other thing that I want to tell you about, along with inhalational injury, going back to the formulas, back to the formulas, is again total body surface area. As I said, guides this therapy, which is why it's calculated so early. This does not account for the depth of the burns. Nowhere on these formulas does it say if a certain percentage of your body burn is deep versus partial, that modifies the formula. And so we have a lot of unknown here. You can have a 50% burn, which is almost 100% deep, or it could be a 50% burn that is only 10% deep. That, as you can imagine, is going to lead you to modify how much fluid you're going to give. But unfortunately, with the formulas, there's no numeric calculation that you can do. It comes back again to your clinical acumen. If I've got a lot of deep burn wounds, a high percentage of deep burn wounds, I'm probably going to have to err on the higher end of the scale. And again, that's why we kind of use a modification that's a blend of the modified Brook and the Parkland, because they are very wide apart. One's double the other, but we know these hard to calculate problems, deepness, percent of deepness of the burn, and degree of inhalational injury pushes us towards the Parkland end of the scale. Whereas if we have much less of those problems, we'll tend to go closer to the modified Brook. Lack of consideration for both can lead to severe under-resuscitation. But as we'll see in a few minutes, if you're not careful, you can lead to over-resuscitation, and that in and of itself is also a big problem. So, to sum up, crystalloids remain the resuscitation fluid of choice. Albumin solutions are also part of the formulas. Again, we use them if we're not meeting our goals. Do you guys have access to albumin? Is that something that is available in your hospitals, or is that something that you wouldn't really be able to use even if you wanted to? Let me see if I can
Yes,
get the. Yeah, you
yes,
can
we can
open your
use
mic or go
albumin.
to the chat.
We can use albumin in the resuscitation process in patients with burn. It's
Okay.
work. No, but here we don't have actually in the government setup, but we can access from the private setup. Still, we can
Okay.
use.
So if you wanted to use albumin, you do have it available.
Yes,
It's
it's available.
oh, okay. Yeah, again, working in the United States, I try to be sensitive to the fact that not, every country has necessarily, everything we do. So I want to make sure that, if I'm telling you something that is something you can never actually deploy, it's more for information. But if you have albumin as an opportunity to use, you definitely will probably want to consider as you develop your own local process in an ICU. So if you become, an ICU director yourself, and you're going to be taking care of burn patients, you may want to develop your own protocol. And if albumin is one of your options, build that into your protocol. And part of the reason why I say that is there is data in the literature that colloids may reduce the risk of excessive fluid resuscitation, which, as I said before, carries its own risk, and we'll come to that in a few minutes. So, adding albumin onto crystalloids, if you are not meeting your target goals and you are already running the crystalloids near the top of your formula, considering a colloid like albumin is probably a good idea. And we'll talk about it in a few minutes, but some institutions are also using fresh frozen plasma. Now, plasma is a very precious resource, like all blood products are. Whether you would choose to use plasma will depend on what you think of the literature. We'll talk about it in a few minutes, but also, depends on what your resources look like. If you don't have a lot of plasma available in your hospital, you may choose to say we need to keep that plasma for other needs, and we're not going to use it as a colloid in burn resuscitation. But if you work in a very large uh, urban hospital in a large city, you may have sufficient resources that you can consider using fresh frozen plasma, and I'll explain to you why in a few minutes when we get to that. As I said, the American Burn Association in the Advanced Burn Life Support course that you can take to get credentialed uses the modified Brook. Okay. But the Parkland formula and again the unmodified Brook are also commonly used. And again, as I said, you can develop your own mix of these formulas if you choose to do so. And that's kind of what we do at Johns Hopkins. All right. We generally target the upper end in the first 24 hours. And again, as I said, we will add albumin, particularly if our urine output is not meeting goals. Keep in mind, formulas are guidelines, not absolutes. You're going to have to modify the situation based on the patient in front of you. We already said the two main caveats are, do they have an inhalational injury, and how much of their burn is deep? So formulas are guides and they are not absolutes, unlike this formula here. Does anybody know what this formula is? I'm a bit of a nerd, so this is actually the Schrodinger's equation from quantum mechanics. But that may be an absolute formula, but in medicine, none of the formulas we use are absolutes. Goal-directed therapy. So what is your target? I've mentioned targets, and this is for all of you football fans out there. What is your target? Okay. Whoops. Primary goal is urine output of 0.5 cc's per kilogram per hour, or about 30 to 50 cc's of predicted body weight in most adults. This gets modified up to 1 milliliter per kilogram per hour in children. Okay. There is some literature that is mounting in the journals around the world that support the adjunct use of base deficit and lactate, so pH and lactate, to help make decisions about whether to increase or decrease fluids. But generally speaking, the advanced burn life support course, that is sort of the standard about how to manage these patients, goes completely by urine output. And I could tell you, we generally do not measure lactate or pH in our burn patients in the first 24 hours. But there is some literature that is suggesting that maybe that's going to need to be modified in the next few years. The problem is other endpoints are not clear whether they are useful, such as point of care ultrasound to look at cardiac output, things like pulmonary artery catheters, which are hardly ever used anymore, or other metrics have not been shown to be as useful as urine output in the burn patient. But lactate may change over the next few years, but right now it is not recommended to follow a clearance of lactate with a burn resuscitation. And one of the concerns with it is because lactate doesn't change as quickly, it may lead to over resuscitation, because sometimes it can be very difficult to get the lactate to clear. And if you chase the lactate with a lot of fluid, you'll wind up over resuscitating the patient. So keep an eye on the literature. How to use lactate and pH may actually become more defined over the next few years, but right now the primary goal is still urine output. It is also absolutely crucial to recognize early on in the first 8 hours, not by 24 hours, in the first 8 hours, that resuscitation is failing. If your resuscitation is failing, your patient may go into refractory shock and you will no longer be able to get them to respond to fluids and they will die. Okay. You then reevaluate again at 24 hours after the initial 24-hour resuscitation. But it's especially important at that 8-hour mark to reconsider, are we meeting our goals? Do we need to change our plan? And the signs of resuscitation failure at that 8-hour mark include things such as persistent oliguria, low urine output, or not making any urine at all, fluid rates that seem to be needed well beyond the TBSA calculation. So if you're using the Parkland formula and you calculated it 4 mils per kilogram per hour, and you are hitting 6 or 7, that tells you something is going wrong and you are failing resuscitation. Something else needs to happen. If the metabolic acidosis, if you're measuring pH on a blood gas, continues to get worse despite being at the top end of your formula that you're using, and abdominal distension. Abdominal distension is a sign of fluid over resuscitation and is a sign of resuscitation failure. And the reason why it is important to recognize this, particularly at the 8-hour mark, is abdominal distension can lead to abdominal compartment syndrome. So as you're resuscitating the patient, what it's telling you is that too much of the fluid is not staying in the intravascular space. It is pouring into the peritoneal cavity and into the bowel, and the abdomen is becoming distended. This will eventually increase the pressure of the abdomen. Your abdomen can only distend so far, and eventually it will stop distending. The pressure will start to shoot up, and it will rob your kidneys, your liver, and your bowel of blood flow. And that will lead to dead kidneys, dead liver, and dead gut, and dead patient. So you have to be very, very cognizant and watch this really closely. Excessive fluid resuscitation, again, carries significant risk of causing this complication and others. The other thing that excessive fluid resuscitation and failure can lead to is the inability to ventilate the patient. High airway pressures on a mechanical ventilator and particularly high driving pressures. Okay, so the mean pressure skyrockets and the peak pressure skyrocket, and the patient becomes difficult to ventilate. That also tells you that you have resuscitation failure and you are giving the patient too much fluid. Now, I will say ventilation can also be difficult because if you have a large burn on the chest, As that starts to swell, even if you're not over resuscitating the patient, can put a lot of, excuse me, a lot of constrictive pressure on the chest. And so the solution to that is deep escharotomies to release that pressure. Okay. Vasopressor need, especially if it is escalating. A person who's getting adequately resuscitated from a burn resuscitation in the first 24 hours generally will not need drugs like phenylephrine or norepinephrine, but sometimes they do. And especially if you have to really increase the dose rapidly, that tells you you are also engaged, you are also having resuscitation failure. Now, what are some of the reasons for resuscitation failure? One of them is you over resuscitated and you've caused congestive heart failure, or you're causing abdominal compartment syndrome. But it also could be because you could have something like stress-induced cardiomyopathy secondary to the shock associated with the burn. Having stress-induced cardiomyopathy, where the ejection fraction and cardiac contractility plummet, can lead to a catastrophic situation because now the heart becomes engorged, it can't pump, and you can't maintain forward flow to the tissues. And this can be an extremely ominous sign of resuscitation failure and carries an extremely high mortality risk. To be honest, unfortunately, there's not a lot you can do to prevent it. And a certain percentage of patients will develop it no matter what you do. Other considerations, as I mentioned, fresh frozen plasma. There is no outcome data, studies that show that it improves outcome yet, but based on some animal studies and what we know about what happens with the pathophysiology of burns, loss of the glycocalyx of the endothelial cells, which I mentioned before, is a major contributor to all that fluid leaking. There is some studies that show that giving fresh frozen plasma is superior to albumin in getting that glycocalyx, that normal layer of proteins and carbohydrates, to reform on the endothelial cells and help improve endothelial function and reduce that fluid leakage. Nobody's done it in humans to prove that it improves their outcome, reduces mortality, but at least based on the scientific data, it may be superior. Again, it's an area of active investigation. Fresh frozen plasma is a precious resource that your hospital may choose to keep for other things and say, well, look, we'll use albumin because albumin's easy to get. We have it in reasonable supply. And until there's outcome data, you probably will want to stick with albumin. But over the course of your career, you may find that the recommendations, especially if outcome data shows that fresh frozen plasma is superior in survival, it may become the choice over using albumin as the colloid. We'll see. It's an interesting area. What about if your patient, if you're concerned your patient's urine output is actually not a reflection of your resuscitation? Okay, this is a huge problem. Patients with chronic kidney disease or patients who are already on dialysis, people who already have end-stage renal disease, right? We said our primary goal for our resuscitation is going to be fluid, is urine output. But if you already don't make normal urine or you already have bad kidneys, it's not a reliable measurement. And some patients who come in because of hemorrhagic shock or other reasons may already have a clear acute tubular necrosis at presentation when they get to your ICU. And so you are concerned that urine output may not be as good an indicator of perfusion and successful resuscitation as you might like. And that could be really challenging. Under those circumstances is when we do have to switch over to other things, such as trying to do ultrasound to look at how well the heart's filled and how well it's pumping. You may need to move over to using lactate to see, try to use lactate clearance as a metric. This could really, really be very challenging. And I could tell you, you will see burn patients who have end-stage renal disease and or chronic kidney disease that is going to make your ability to use that goal endpoint much more challenging. You're going to have to consider how you are going to guide your therapy. Nutrition. Absolutely, absolutely important. right at the beginning, not later, at the beginning. This is part of the resuscitation. Burn patients are incredibly hypermetabolic. Incredibly. It's like running a marathon constantly. Okay. Even worse. Aggressive nutrition needs to be started immediately. We immediately place a feeding tube, either a nasogastric tube is our preferred one, but an oral gastric tube is fine. And we start nutrition. Our goal is to get tube feeds, nutrition feeds, running down the tube into the stomach within 4 hours of arrival. You have to give these people calories, protein, carbohydrate. They have to get it immediately. You can't wait to the 24-hour mark or 48-hour mark. This has to start immediately. Literally, you are barely 4 hours in your resuscitation, and the food needs to be going in. Okay, so don't forget about nutrition. Fluid creep. You can see here we have a creeping little drop of blood or drop of fluid. This is a huge problem in burn resuscitation. Remember back to our formulas? The modified Brook formula uses 2 milliliters per kilogram per total body surface area. We already said the Parkland formula is twice that. Okay. The risk here is that we give too much fluid. We already mentioned that abdominal compartment syndrome is a major risk associated with giving too much fluid. And it may occur even if you are giving the right amount of fluid. But certainly if you over-resuscitate the patient, you will engender the risks of congestive heart failure, abdominal compartment syndrome, which will lead to an emergent surgery to open up the abdomen to release the pressure. And you may now also have complicated things by causing acute kidney injury or kidney failure. You may have complicated problems by causing liver damage because of lack of blood flow to liver. And the most devastating one is if you've caused dead gut. You know, if the patient's gut dies, they're going to die. And so you have to be really careful. And the term that we use to describe this problem is fluid creep. We start off, within the framework of our formula, but we wind up going too much. We wind up, the urine output's not quite good enough, and we wind up giving too much fluid. We get too aggressive. So, burn resuscitation is a real artful balance between avoiding shock and avoiding too much fluid. And fluid creep is a real problem. It happens all the time. In fact, we actually keep very close tabs on all of our burn admissions in our burn ICU about exactly how much fluid they got. And when we wind up with episodes where a patient had fluid creep, they got too much fluid, we try to reassess why that happened. Sometimes there are legitimate reasons to explain it, but often it just we weren't as careful as we should have been. Okay. Almost every study will demonstrate that if you look at how much fluid a burn patient got, they very commonly get much larger resuscitations than they should based on the formulas. But as we said, the formulas themselves already have wide ranges. So that partially explains it, is that there's too much uncertainty in the formulas. And so you can wind up with way too much fluid. Okay, so one study, a review of the modified Brook resuscitation formula, showed that rather than getting the 2 cc's they should have gotten, most patients received almost 5 cc's, more than almost 2.5 times what they should have gotten. Looking at the Parkland formula, which already uses much more fluid than the Brook formula, the studies showed similar results. Instead of getting the 4 that was calculated, they got 6.9. Again, though, some of that creep may have been because they had a bad inhalational injury. Okay. Some of that creep may have been they had a large area of deep burn. But we have to be careful about not really over resuscitating the patient. And fluid creep has been reported in as often as 90% of patients with greater than a 10% TBSA burn. And I would argue that fluid creep is probably more common when the burn is even larger, because it just gets so much harder to be sure about how much fluid to give the patients. So some of the reasons that come out of the literature: overestimation of the TBSA. Instead of, we think the patient's got a 75% burn when in fact they've only got a 60% burn. So you have to be careful about the TBA estimation. And while we get that estimation up during our initial survey, it is always good to reassess that as you are moving through the first 24 hours of resuscitation. Re-examine the patient, determine, was that number accurate? Is it too high or is it too low? Okay. Overestimation is not an uncommon problem. Inattention during resuscitation. This resuscitation is a 24-hour activity. So that means it has to go all through the night. At night in our hospitals, particularly in our ICUs, we know that resources tend to drop. And so it can be very easy to not be paying as much attention as when you have more people around, more nurses, more doctors as you do during the day. So you have to be careful because it is, nighttime and daytime, it's the same thing. Delay in transport to a burn center. Obviously, as I said before, it's important out in the field, the ambulance to start fluids if they can. A long transport from the site of the burn to the hospital, particularly if fluids were not given, sets you guys as ICU doctors so behind that it's very hard to catch up. And the attempt to catch up often leads to severe fluid creep because the patient has now been in deep shock for so long that the inflammatory response is so tremendous that it just gets completely out of control. That is a huge problem and often an issue. And also it's not just the delay. It's like if the person's in a burning house, you have to get the fire under control to get the person out. And so patients may be in a burning building or location for an extended period of time before, medical personnel can even get to them to transport. So there's a lot of reasons why this happens. Distance, extrication difficulties, other things can make it hard to get the patient to the hospital quickly. And people have also argued lack of colloid administration during the resuscitation, which is why people really like modifying the Parkland and the Brook formula to add albumin, and that's why we do it. And again, maybe in the future, fresh frozen plasma might become part of that formula. The danger with fluid creep, of course, as we've already mentioned, is it leads to adverse outcomes. It increases the risk of abdominal compartment syndrome of the eye, of the limbs, basically throughout the body. It increases the risk of acute respiratory distress syndrome, pneumonia, multi-system organ failure, and increases the risk of mortality. So that ties into some common complications of burn resuscitation. Here we have a picture of an extensive burn, as you can see. Most of the burn tissue has been taken off, but this person had to have an exploratory laparotomy because they developed abdominal compartment syndrome. They had to open the abdomen to release the contents of the bowel because the patient was going to infarct their bowel because they got a very aggressive resuscitation and their abdomen swelled up, the pressure shot up, and they risked killing their kidneys, killing their liver, and killing their bowels. The other thing that can happen is you get orbital compartment syndrome, which can lead to blindness. Okay, a canthotomy is the treatment for that should it occur. Literally you shove scissors into the corner of the eye here and you cut this open to release the pressure. Okay, extremity compartment syndrome is very common just with the burn alone. And we often have to do escharotomies where we cut the tissue down and release it, just like fasciotomies for ischemic reperfusion injury. Excessive fluid resuscitation increases the risk of this. Okay. The inability to ventilate the lungs due to the chest wall edema, which can be exacerbated by fluid creep, but may occur completely on its own. Escharotomies, as you do for the arms, helps with that, but you may have to excise a lot of the chest tissue. As you can see here, a lot of the tissue had to be taken off this patient's chest. And again, worsening of ARDS. Lungs are happiest when they're dry. ARDS already leads to fluid leaking into the lungs. If you over-resuscitate the patient, you are just going to drive hydrostatic pressures that's going to make more fluid move into the lungs and make ARDS worse. And of course, electrolyte disorders are very common. Hypernatremia, hyponatremia, potassium problems, calcium levels, all kinds of electrolyte disorders occur with burn resuscitation. And you need to be watching these labs very frequently as you can, while you do this kind of resuscitation, so the patient does not wind up with a severe electrolyte disorder. So, crazy first 24 hours. It is it is a crazy resuscitation where, I mean, I can tell you, I've literally been at the patient's bedside every minute for 24 hours. It is exhausting, but if you do it well, you can set your patient's course up for success. If you fail in that first 24-hour resuscitation, your chances of a successful recovery for the patient diminish dramatically. It's really, really important and crucial. But at the 24-hour mark, and again, this is somewhat arbitrary, I'll be honest, at the 24-hour mark, this aggressive, massive resuscitation process ends very abruptly, and fluid resuscitation switches to traditional endpoint goals, just as you would for sepsis, and is no longer based on TBSA, total body surface area. We then switch over to standard therapy, and of course, all the things we watch for, such as infection, kidney injury, etc. And we manage our fluids and our resuscitation based on traditional lab values, including transfusion of blood products, fluids, additional colloids, etc. Okay, so literally at the 24-hour mark, the process, the switch flips off and goes back to standard ICU resuscitation processes. We also move right then into early debridement. Usually we like to get the patients to the operating room to debride the dead tissue. Not usually right at the first 24-hour mark, but once the first 24 hours are hit, we like to get them to the operating room in the next 24 to 48 hours. If you wait much longer than that, they will get infected. And they will be right back in a massive resuscitation due to septic shock. Wound coverage, as we've talked about, becomes the focus. Watching for infection becomes the focus. Also, something you should consider is early tracheostomy. Okay. As I said, the burn patients, if you have a 50% burn, the data and literature suggests that patient is probably going to be in your ICU for 50 days on average. And they're going to spend a lot of that time probably on the ventilator. And they have to go back to the operating room many times to get the wounds excised and to try to cover them. It's good to get these patients early trachs because they are going to be on and off ventilators for a long time. They're very high risk. And early tracheostomy has been shown to reduce the risk of ventilator-associated pneumonia, which can be a devastating complication in these patients. So I always advocate for early tracheostomy. Now, one of the downsides of it is if the neck is burned, it's hard to do a trach through a burn. You can, but it's not good. So usually when we're planning these steps out with the surgeons, we ask them is, can they graft the neck early? Can that be one of the first areas that they clean up and graft? Because within a week or so of getting the graft on there, we can actually usually do the tracheostomy through the graft. So we usually go for early grafting of the neck if the neck is burned, and consider very early tracheostomy. Of course, after the first 24 hours, as we've already mentioned, management of complications, management of the risk of ARDS. You want to have the patient on a low tidal volume strategy to try to protect them from ARDS. You want to watch for it carefully, manage acute renal dysfunction, which is common. Infection is probably the biggest risk of the patients once we get out of that first 24 hours. As I said, multiple trips to the operating room are very common, and the resuscitation really often remains an almost constant activity, usually for the first few days. And it's still pretty aggressive, although not based on TBSA and not as aggressive as in the first 24 hours. But of course, you have to manage the situation. So let's say the patient goes to the operating room on day 2 or 3 to get a lot of tissue excised. If that patient winds up getting a lot of blood products and they start getting into coagulopathy, you may find yourself back at a very aggressive blood product resuscitation with plasma and red blood cells. You kind of have to watch and see what happens. Some patients bleed a lot, some patients don't, and so you're going to have to really kind of, as the expression goes in the United States, go with the flow. You're going to have to watch and see what happens and make your plans, tailored to that patient. But while the first 24 hours ends, so to speak, the resuscitation is still ongoing, usually for at least another week until enough of the body surface area is covered that we generally have a good control of the wounds. And then, of course, unfortunately, we really have to watch for sepsis and septic shock. These patients are incredibly challenging, which is why burn ICU care and taking care of burn patients in the ICU, whether it's a specialized burn unit or not, is really it really tests your ICU skills. It tests your ability as an intensivist. It could be thrilling and a challenge, but it can be exhausting. But it is very rewarding when you see a patient survive and leave your ICU and leave the hospital to go home. Um, Large burns carry a very high mortality, and every patient who survives, should be celebrated. Questions?